Hello and welcome to this episode of sMater, a podcast by clinicians for clinicians, brought to you by Mater, an Australian leader in healthcare for more than a century. I'm your host, Gillian Whiting, coming to you from Meanjin, the land on which this podcast is being recorded.
And I'm Dr. Maria Bolton, GP specialist and former president of AMA Queensland.
Today we are joined by Professor Aileen McGonigal, Clinical Director of the Mater Epilepsy Unit based at South Brisbane and Research Group Leader.
We are Mater.
We are Mater.
We are Mater.
This is sMater.
Aileen, welcome to sMater.
Thanks very much. Delighted to be here.
Can you give us a snapshot, firstly, of epilepsy in Australia today? How common is it and who does it affect?
Yeah, sure. So epilepsy is the commonest serious long-term, so chronic neurological condition, estimated to affect 250,000 people in Australia, so 250,000. It's a significant burden to the people, their families, to society, because of course people with epilepsy often can't work, can't drive. It really can affect anybody. It affects the whole lifespan from infancy, childhood, right up to old age. Epilepsy can occur at any time of the lifespan, although there is a peak in children and a peak in older people.
As a GP, I find navigating epilepsy diagnosis and treatment a bit tricky, so I'm so pleased to be speaking with you today. What drew you to epilepsy?
Well, that's a good question. So I did my studies in the UK, in Glasgow in Scotland, in neurology. So I'm qualified as a general neurologist, of course, treating stroke and multiple sclerosis and Parkinson's disease and all the other conditions. I was particularly fascinated by epilepsy, partly because it's so complex and so difficult, can affect people in lots of different ways with many, many different manifestations which occur in short periods of time. I think I was particularly interested in the ability to record the brainwave activity through electroencephalography. So that's electrodes usually on the scalp, which can record the brainwaves during the seizure. So we can actually study in a lot of detail the brain changes underlying all the manifestations of epilepsy, which, as you know, can affect conscious level, memory, movements. People might be prone to fall, might even have convulsions. One way that we can think about epileptic seizures is like a brain arrhythmia. So we know about arrhythmias in the heart. The brain's much more complex than the heart as a structure, and an epileptic seizure is like a disorder of the brainwave rhythms, which occurs during seconds or minutes, and depending on which part of the brain it affects, that will determine what the person feels and what everyone can observe.
Now, you've just launched the Australian Epilepsy Project. It's the world's largest and most comprehensive epilepsy study. What is it, and how is it different from other epilepsy studies?
Yeah, so this is a great initiative. This is led by Professor Graham Jackson at the Florey Institute Melbourne. So we are collaborating with his group, and many other teams around the country are part of this exciting initiative. The goal is really to collect a very large cohort of epilepsy by studying people with different forms of epilepsy and basically inviting them to take part in a series of tests. So one of those is a high-level MRI, magnetic resonance imaging brain scan, which goes beyond what is usually done in the hospital setting in terms of being a higher resolution scan. So we see in much more detail any very subtle brain abnormalities that might be the cause of the epilepsy. There's also some testing done during that scan of brain function. So people in the scanner will be asked to do some tests for language or memory, and that really shows us which parts of the brain light up, and we can understand if their brain function has perhaps been altered due to epilepsy. And then there are also some tests on cognition, so memory, language, and so on, which are conducted over telehealth with expert neuropsychologists. So we really get a snapshot of not just the seizures, which of course are the main impact on people with epilepsy, but also all of the issues in the background, which are mental health and cognition, which are actually related to the impaired quality of life. And then the last part of the testing of the Australian Epilepsy Project is a genetics test, which is done at home with a mouth swab for a saliva sample for testing for DNA. So the goal is to really offer this very high level testing to people all around the country. So, of course, someone with epilepsy who lives in the city centre, perhaps in Melbourne, where there's very big academic hospitals, it can be quite easy to access these types of tests, in a routine way almost. Whereas people living in more distant regions, especially here in Queensland, where we have a lot less in the way of epilepsy services compared to some other parts of Australia, they're often disadvantaged by not being able to access the high-level technology and the high-level specialist expertise. So this project really kind of highlights that gap and makes it accessible for people to have the best quality imaging looked at by very specialist neuroradiologists, and then to have the high-level psychology. And the best thing about it for the patients who take part is that the results are then transmitted back to the referring clinician, who has to be a neurologist, and we can share those results with the patient, and it often then affects their treatment in real time. And then in the background, we're collecting this huge data set, which will lead to new knowledge about different forms of epilepsy and lead to hopefully better diagnosis and treatment in the future.
It is huge, clearly very important. How many people? What's the duration? Is there any more you can tell us about the project?
Yeah, so the goal is to enrol 4,000 people around Australia. So here in Queensland, our kind of target is to enrol 1,000. So we're key partners in this study, which we're very proud to be, and it's really thanks to the amazing support from sMater Research that this has been made possible. And we're so far, I think, up to about 500 recruitments. So we're already, halfway there, which is really great. So the goal is to, as I said, enrol this large population. The study organisers are keen to have a sample of healthy volunteers in there so that we can also have some brain scans of people without epilepsy, their neuropsychology and so on, to compare the differences of brain function between people with epilepsy and people without epilepsy.
According to the Epilepsy Foundation, people over the age of 60 are now the largest group of Australians living with epilepsy. 1 in 200 Australian children live with epilepsy, as do 1 in 4 people with a profound disability.
How do you think the findings will potentially change the way that epilepsy is diagnosed and treated?
Yeah, that's a good question, because I think it's got actually quite far-reaching impact for people in Australia, but also I think other countries around the world will look to this study and learn from it. So I think to go back to what I said about the kind of access and equity of, being able to, have the high-level testing, the goal of this study is actually to show that if we do make high-level testing available, especially early in the condition, ideally as soon as possible after the first seizure, actually, then we can have a chance to affect outcomes. So that, for example, some people with epilepsy have epilepsy due to a cause that could be treated surgically. Most people with epilepsy, to take a step back, are treated with medication. So as you know, and the listeners will know, the mainstay of treatment is anti-seizure medications, of which we now have more than 20 different molecules in the market, which are taken every day, and their role is to stabilise the brain rhythms and avoid the risk of these arrhythmias, which are causing the epileptic seizures. So it's really a preventative treatment to stop the seizures. But of course, it doesn't tackle the cause of the epilepsy. Epilepsy can be caused by many, many different conditions. And in some people, it's fairly straightforward to work out why they have epilepsy. They might develop seizures after a stroke, or they might have a first seizure and then they have a scan and it turns out to be a brain tumour or something else like that. A structural lesion that we can see. Other people might have a genetic cause for epilepsy. The brain scan might look normal, but we might know that they've had a family history of epilepsy, and that might, point towards a genetics cause. But nearly half of people don't have a clear-cut cause like that we can really put our finger on. And yet, as the imaging, the neuroimaging becomes advanced, we're starting to see more and more very subtle brain abnormalities, which are actually the cause of the epilepsy. And many of those are congenital, meaning that there's been a development problem in the brain before birth. The commonest of these is called focal cortical dysplasia. This is where a few of the brain cells during development migrate into the wrong place. They connect up in an abnormal way, and that kind of poor connection leads to electrical instability, which can predispose towards epileptic seizures. So going back to what the study can tell us, as we do these higher level imaging testing, we're starting to see more and more of these subtle abnormalities which cause epilepsy. And that's important because apart from the importance for a person with epilepsy and their family to know why it's happened, that's very important psychologically, of course, but it might also open up new treatment options, because when we've tried medications, the GPs listening will know that many people don't have good control of seizures despite medications. In fact, up to a third of people have what we call drug-resistant epilepsy, meaning that despite adequate medications, and we define that as being failure of two medications, once someone has tried two appropriately chosen, appropriately dosed medications for seizures and their seizures are not well controlled, at that point they should be referred for specialist evaluation, because there might be other treatment options, including surgery for some people, that could bring about seizure control.
You mentioned genetics. What role does genetics play in epilepsy?
So genetics probably plays a huge role in epilepsy beyond what we know nowadays. We certainly know that some forms of epilepsy are purely genetic, so there's no other explanation. And in the testing that we can do nowadays, we can find a gene that's caused the epilepsy. So there's a certain number of genes that we call those monogenic epilepsies. So a single gene abnormality causes the epilepsy. Then there are all of the kind of less well understood genetic abnormalities which contribute to a tendency to epilepsy that might not necessarily express, but in some people it will do. And in fact, we think that as technology advances, as we have better access to genetic testing for more people, we'll probably start to find more and more genetic abnormalities. In the Australian Epilepsy Project, the testing that's done is called a chromosomal microarray. So it's a fairly low-level genetic screening test. There are then much more high-level genetics testing that can be done if we find any abnormality on the first-level testing.
You mentioned we need 1,000 Queenslanders at least for the study that you're hoping to recruit.
Yeah.
What are the eligibility criteria and how can GPs help, particularly thinking about candidates from outside of Metro?
Yes, that's a good question. So there are 3 groups of patients who can be enrolled into Australian Epilepsy Project. The first group, which our team has contributed the most of, are called focal drug-resistant epilepsy. So as I mentioned, drug-resistant means a diagnosis of epilepsy where medications are not sufficiently controlling seizures. Focal means that seizures are coming from one hemisphere, so one part of one hemisphere. They're usually coming from a localized region in the brain. And defining that usually needs a neurologist to diagnose that. So the best thing a GP could do if they think they have patients in their practice who might be eligible would be to refer that patient to a neurologist. Doesn't need to be an epilepsy specialist. Our team here at Mater are epilepsy specialist neurologists, but any neurologist can refer a patient to Australian Epilepsy Project. So refer to a neurologist if you think your patient might have focal drug-resistant epilepsy. The other 2 categories are really about the idea of trying to fine-tune as much diagnostic information as possible early in the condition. So we can include patients with a recent diagnosis of epilepsy within the first 6 months after diagnosis of any form of epilepsy. And then the last group is patients with a first seizure. And even when we're not 100% sure whether it's an epileptic seizure, as we know often it's not that clear-cut in the first instance, but those groups of people are important to understand whether perhaps if we were able to offer high-level testing early rather than wait for years, perhaps we can improve outcomes for those people.
How important is diversity in this study? So different ages, different backgrounds, all those kind of things.
Yeah, so the study is enrolling adults with epilepsy. So the age range is 18 to 70. Of course, that's in the context of this research study, but in clinical practice, we look after people with all different ages. We work closely with the Queensland Children's Hospital, who have an excellent epilepsy team, and we really endeavour to have a smooth transition of care between the paediatric age group and the adult age group. So, for example, our team at Mater will have meetings with the Queensland Children's Hospital team discussing complex cases, especially those who might be surgical candidates who have the drug-resistant epilepsy form, which is what our team at Mater particularly looks after, and really try to smooth that passage, which is often occurring in the teenage years, often a difficult time for anybody, never mind a young person living with a complex condition like epilepsy, which is impacting their social life, perhaps their schooling, their work options, their ability to drive, and so on. So we try to provide a transition with psychological support and education, as well as the standard clinical care for those young patients.
Would it be useful for GPs to flag that a patient might be a candidate for the study, just considering sometimes we are faced with waiting lists? Or would it be more useful for the GPs, particularly in rural and remote, to refer straight to the sMater Epilepsy Clinic?
So I think that at a GP, so you're quite right, waiting lists are a problem. I mean, they're a problem for everybody. As I said, any neurologist can refer to this study. So the best thing a GP could do would be to refer the patient to their local neurologist. The local neurologist may or may not be in the habit of referring patients to the sMater epilepsy team. In fact, they don't need to do that for the purpose of this study. The neurologist in Townsville, for example, could then enrol the patient via the website, and our team at sMater would then deal with the referral and work out the logistics of having the patient come to Brisbane for the scan, for example.
Are there any risks or burdens or costs for patients who want to be involved in the study?
So definitely no costs. Everything's provided free of charge. And as I said, this is a very high-level set of investigations which they wouldn't normally have access to. So it's really an added value to take part in the study. I would see it like that. And most of the patients and families have been really delighted with being able to take part in that. I guess the main burden is going through extra tests. So, of course, people with epilepsy often have had a number of tests in the hospital, an MRI scan, an EEG scan. So they may say, well, why do I need another MRI? I think the answer to that is that in the study so far, although we have good level imaging here in Australia, in Queensland and elsewhere, in fact, because of this more detailed research protocol that's being done on these MRI scans, we've actually found that 10% of people participating have had something, an abnormality detected on the scan that wasn't recognised in the previous hospital scan. So that's quite a high level, and it's even led, as I said, to changes in practice. We had a young patient who's 20 years old who's just undergone epilepsy surgery up in the hospital just last week, and he was originally considered to have a negative MRI scan, normal imaging, so we didn't know why he had epilepsy. And we were preparing all kinds of invasive tests to try to, understand that better. Then, in fact, when he went through the Australian Epilepsy Project, we found out two very important things for him. One was that we found a lesion on the scan called an encephalocele. It's like a tiny bulge of brain at the very front of the temporal lobe, which is operable. And then the second very important thing is that he was found to have reversal of his language dominance in the functional testing. He wasn't left hemisphere dominant, he was right hemisphere dominant for language. And that meant that he could safely be operated on the left hemisphere for this tiny encephalocele, have it removed with no deficits and no invasive imaging, no invasive recording needed before surgery. So that's quite a transformative set of investigations for that patient's care. And if we even find that in a smallish number of people, that is definitely worth going through the study.
A 2025 study titled A 10-Year Projection of Adult Epilepsy Burden in Australia reveals a significant and growing health challenge. Researchers estimate that between 2024 and 2033, over 82,000 adults will develop epilepsy, adding to the existing population of those already living with the condition. The projected impact includes over 15,000 deaths, nearly 1 million quality adjusted life years lost, and $14.2 billion in healthcare costs, much of it driven by drug-resistant epilepsy.
Can you paint a picture for GPs of what the patient experience is like coming to the sMater Epilepsy Unit?
Sure. So the first thing is that our core patient population that we see at sMater Epilepsy Clinic are people with drug-resistant seizures. So many of my colleagues in general neurology also look after people with epilepsy, but we especially in the sMater Epilepsy Clinic look after people whose seizures are not well controlled on medications. And the reason for referring people to our team or to other teams around the country, which are similarly specialist epilepsy teams, is really to confirm the diagnosis. So as the GPs know, often it's not so clear what are causing seizures. Sometimes people have epileptic seizures, but non-epileptic seizures, so functional psychogenic seizures, can also mimic epileptic seizures. People might be treated for years with anti-seizure medications, and it turns out not to be the right treatment for them. So any doubt as to diagnosis, is it epilepsy or not, should have a referral to the hospital. The people we see most often tend to have epilepsy confirmed, but we're then trying to fine-tune the classification of which type of epilepsy and the cause of epilepsy in order to explore treatment options beyond the medications that the person's already tried unsuccessfully. And so we are seeing people in our epilepsy clinic. We're a group of consultants. We work closely with our epilepsy nurse. It's a very multidisciplinary team. We also have neuropsychology, clinical psychology, neuropsychiatry, speech pathology, because people with epilepsy can have language issues as well. We work very closely with neurosurgery. So we're a whole team, and a lot of what we're doing is sharing all the expertise from the different team members to try to understand and manage as best as possible each person's epilepsy. It's a very individual condition, so it does need quite a personalised approach. People are seen in the epilepsy clinic, and we'll be going through all of their history, trying to understand what the seizures are like, their past history, any risk factors for epilepsy, understand their current medications and treatments and what they've tried in the past. And we will then be deciding, does this person need extra testing? So that might be enrolling them into Australian Epilepsy Project, is what we're doing quite often at the moment, checking if they've had the appropriate MRI testing, looking at other brain scans such as PET scan, which is positron emission tomography, which looks at brain metabolism. And then a big part of our work is using electroencephalography, EEG methods, to better understand that person's epilepsy. And that can be an outpatient EEG, which takes 30 minutes or so in our outpatient departments, or we bring people in to monitoring in our hospital unit, where people come in usually at the start of the week. They stay for 5 days or so, and we continuously monitor the brainwaves in a room with a video camera. And we are often reducing medications in order to capture seizures, because that allows us to examine the patient during the seizures and understand exactly what the symptoms and signs are, because that gives us clues as to which part of the brain is causing the seizures.
And you mentioned before that epilepsy is like arrhythmias for the brain, and it sounds like you have Holter monitors for the brain as well, like we do for cardiac arrhythmias.
Yeah, correct.
That people can do in hospital or out of hospital.
Correct, that's right. So we also use ambulatory EEG, which is where the patient comes to a hospital, has the electrodes placed on the head, and then goes home with a portable setup, and we can record for 1 night or 2 nights, and they come back to the hospital, and we can then really study what's happening, especially overnight, where often it's difficult to know if people might be having seizures or not. So these technologies are very, very useful for people with epilepsy.
What about AI and this kind of work, and what does the future really hold for epilepsy study?
Yeah, so AI, that's a great point, because I think AI is coming. We all know that. It's coming in medicine. It's used already in some hospital settings. I think it's got great potential for the world of epilepsy. It's being used in the Australian Epilepsy Project to analyse some of the MRI data. And for example, when we get the report back for the Australian Epilepsy Project, we have automated quantification of the size of the hippocampus, for example. It's a structure in the brain which is often prone to become epileptic, and the AI can help to measure the size of that, and we get that as part of our report. In terms of EEG, we're using some AI methods in the Mater Epilepsy Unit. We're using that to help us, for example, quantify the number of epileptic spikes on the EEG that patients have during long-term recordings. So I think it's got huge potential to help with analysing this type of complex data, of course, complementing the clinician's human perception of it.
It's not going to take your job.
I don't think it'll take our jobs. I don't think so.
What advice do you have for GPs as we support patients and parents of patients who have epilepsy? I mean, it's a big diagnosis, and it has a huge psychological impact.
Yes. Yeah, I think the psychological impact is definitely huge. I think it's important to know that people with epilepsy are much more prone to anxiety and depression than both the general population, but also compared to people living with other long-term conditions like diabetes. And it's thought nowadays that this predisposition to psychological issues is actually part of the brain dysfunction, if you like. It's not just a reaction to having to live with this terribly difficult diagnosis of not knowing when I might have a seizure. Will I fall down? Will I, be able to start a new job? Will I ever be able to drive? Will I ever be able to get married? These kind of really life-changing effects of seizures, which are devastating if the epilepsy can't be well controlled. So it's important for practitioners to understand that the anxiety and depression are real components of the condition. And as I mentioned earlier, we know that from studies that those are a major contribution to poor quality of life in people with epilepsy. And then the other issue, which is often tricky, is the memory or cognitive issues that can also be part of the epilepsy diagnosis, sometimes aggravated by some of the medications that we give that can also, increase, have side effects on mood as well, which can be negative. So I think it's important to try to look at the whole picture. And although our main goal is to try and treat the seizures, we have to kind of think about the whole person and think about the support that we can offer, which might be referral for a mental health plan to get some psychology input. We use our psychology team very actively in our multidisciplinary team setting, because lots of our patients need support with neuropsychiatry and neuropsychology.
So much happening in this area. What would you say to GPs who want to know a little bit more about the AEP or any other advice? Can you point them to in any particular direction?
Yeah, sure. So the Australian Epilepsy Project has a great website. So it's very comprehensive and, designed for patients and their families to look at as well. So that's very good. And we can maybe put the details of that in the show notes. I think two resources that we recommend a lot for patients would be Epilepsy Queensland. So that's our local biggest, consumer advocacy society, which is excellent. It has some great resources on their website. And then Epilepsy Action Australia is also an excellent resource. And as clinicians, we work very closely with these consumer groups, and their websites are very informative, talking about some of the effects of epilepsy, the different types of epilepsy, the treatment options, advice on driving, that type of thing.
The Australian Epilepsy Project is a huge study with thousands of people. How long are you going to be recruiting candidates for, and when can we expect to see the results?
So the recruitment will definitely continue this year, next year. I think hopefully by the end of next year, the total number will have been achieved. So by the end of 2026. Results are starting to come through all the time because, of course, we have some interim analyses, and the figure I mentioned of 10% of abnormalities on MRI is already a huge result, actually. So the study team are digging into the different abnormalities that make up that 10%, and that will be getting published quite soon. I think results will continue to come out because this data set is very precious. So I think with some of the more detailed analyses, we'll see results that will impact Australian epilepsy care and also other parts of the world over the coming 5 years or so. I think the real goal, though, is actually to use this study and use the results to change the current practice. I guess one thing we'd like to do is to make it standard to have an excellent level MRI as early as possible in the condition and make that accessible to everyone who has an epileptic seizure. So the goal would be actually to make this the new normal, that people with epilepsy have high-level investigations early in the condition rather than waiting for 10 years, 20 years when nothing really works.
They're huge results, Aileen. Congratulations on such amazing work, and thank you for joining us on sMater. Before you go, though, a few back to basics questions from Maria.
Sure.
You mentioned how important a high-level MRI is. As a GP, we like to order those as the patient gets referred to a non-GP specialist. What should we order? What should we write on that referral so that the patient gets the best MRI possible?
Yeah, that's a great question. So the easy thing is to write MRI head, epilepsy protocol, and the neuroradiology teams will know what that means. It essentially means that we have high-level scanning through the mesotemporal regions, the hippocampus in particular, and that the scan goes far enough forward in the brain to capture all of the temporal lobes, which are one part of the brain that are most often epileptic.
In addition to that, what about blood tests?
So I would say there are no routine blood tests needed. The most important thing actually is the clinical history. It's establishing what happened, the circumstances of the seizure, what the patient could feel, what bystanders observed. That's actually the most important information of all, is the clinical history. So that really is back to basics.
And back to the psychosocial effects of epilepsy. If you have a patient who has epilepsy who needs medication for anxiety or depression.
Yep.
Is it okay to use the commonly used SSRIs or SNRIs? Are there any contraindications?
Yes, definitely. That question comes up a lot. So the SSRIs, SNRIs are safe to use in epilepsy. There's often a misconception that antidepressant treatments could change the seizure threshold. And sometimes we do see patients who've said, well, no one wanted to give me an antidepressant in case that affected my epilepsy. That's true only for the older generation antidepressants, like the tricyclics. We do, if possible, avoid those ones, but the newer generation SSRIs definitely safe to use, and we definitely prescribe those a lot for our patients.
That's excellent. Thank you so much. And that'll help for all our CPD as well. Thank you.
Thank you.
We've covered so much ground today. Professor Aileen McGonigal, thanks again for joining us on sMater. For our listeners at home or in the car or having a well-deserved break between patients, thanks for tuning in.
See you next time on sMater.